here.
Ellie.
I don't know about all of you, but I had a kind of an empty Friday, and then I didn't. Like, crazy. Oh, good.
Hi, everybody.
Oh, good to see everybody. Hi, Brooke.
A talkative group.
Mark, you're going to leave your name like that the whole meeting, aren't you? I like it.
This computer is too old to change my backdrop, but I could come up with some pretty fun things for that too.
I just got line after line rolling through my head.
Come on, it's Friday. We need to lighten up a little.
That's good.
Hello, everyone.
Hello, Jane Marie.
I did a Zoom call. We have a weekly with a community group here where we used to gather. There's an antique bookstore in town here. And every Friday they do a happy hour, wine and cheese and things like that. In the summer, it's outside in the parking lot. Inside in the winter, we come inside and we do it. And now we do it virtually like this every Friday. So last week was like silly hat week. So, you know, there were a couple of guys wearing a fez. You know,
Nice.
a bowler hat. Like, who has a bowler hat in the house? I guess as many people as have a fez, you know. And so, you know, just kind of lighten it up a little bit.
That's good.
Oh, the gang's coming in. It's great to see everybody.
Mm-hmm.
Just think where y'all are, all across the North America. Pretty exciting. And Canada. Cool beans. Sally's looking exceptionally good these days. Look at that photo. Oh.
Well, it's 1 o'clock. Should we begin? Respect people's time. Wonderful. So a couple more people might trickle in, but welcome everyone. So today is really exciting because it's an add-on, but I think really important information to be shared. So I think we also have an hour, so we have a lot of content and questions, so let's just jump right in. I just want to say thank you to Brooke and Gregg from the Watershed Center for bringing this the conversation and also inviting a best friend, but also an amazing medical expert. And Brooke or Gregg, I invite you in to introduce the speaker and a little bit about how this came to be.
Sure. Thank you so much. There's a little bit of a echo, and I don't know if there's an echo with me as well. No, okay. Well, I am really thankful, and I'm so heartened to see how many people showed up, and I'm so thankful, Caesar, I see you on here, for your time, given how exceptionally busy you are in this moment. And I actually, Gregg, my partner, was wanting to introduce Caesar just because he's his best friend from college. And so this is an exciting opportunity. This is the first time we've actually found our worlds
Would you prefer we stay upstairs?
that way. So Gregg is still doing baby care, but he's about to introduce Caesar.
Sorry, hey everybody. So I don't know how to be unbiased about this guy. Caesar and I have known each other for about 25 years, and you've all hopefully had a chance to read his CV. He's an incredibly competent and experienced medical professional who's done incredible work over the last 5 to 10 years in particular around trying to innovate around the patient experience, to make going to the doctor something that actually is not intimidating, isolating, or ostracizing, but actually something that's restorative. And but on a personal level, what I'd like to just say is he's just an incredibly compassionate, grounded, and even-keeled person, probably the most even-keeled person I know. And if I were to ever go to an emergency room, he's the person that I would want to see me. And so in this moment where so many of us are incredibly just living in uncertainty and a lot of anxiety and nervousness, I thought he would be an incredibly grounding voice for us all, to bring both really cutting edge and frontline information to us, but in a way that is balanced and something that we can actually hear without freaking out. And so with that, that's my little introduction. I'll turn it back to Brooke.
Thank you. And so how this came to be, just so Caesar knows, we mentioned very briefly, we have this amazing network of retreat center directors and workers from around the country. And we are all in a moment, as you know, of great pause, because we don't know whether we don't know if we have a future, some of us, and we don't know when we can reopen. And so we've been meeting, doing emotional support and talking about all different types of topics, including the PPP money and economic concerns. And of course, we've discussed medical things in short form. We've had a doctor join one of our calls who was participating, but really wasn't holding the center stage. And I had mentioned you, Caesar, as somebody that we had been talking to, selfishly trying to figure out our own retreat center woes, and you graciously offered to give us an hour of your time. So I will not take up any more time with introductions, but we also, as a group, came up with a bunch of questions for you. We shared them with you, and I shared with Caesar that he shouldn't feel obligated to address questions that he doesn't feel like he can answer, but I think he sort of has the gist of what we're looking at, both in terms of the sort of the nature of retreat centers, which have very close proximity and high turnover, and where we've got sleeping quarters and food services, and really just trying to figure out what would be safe, and a lot of vulnerable people. As you can see, many of us are, I would say almost all of us are over 40 on this call, but some people are in, or even are elders and higher risk. And so really figuring out what could be a safe scenario for us to open our businesses. And there's some questions around short-term retreats and some looking at longer-term residencies, but you have all the questions, and I can facilitate you as much as you'd like, or you can just sort of hold forth and we can listen. And maybe we can have you talk for the first 20 minutes, and then we can see where we're at and see if there's questions. If people want to ask questions, I can try and keep track of them in the chat box as you go. And yeah, so thank you so much, Caesar. And you are muted.
Thanks everyone for having me, and I apologize like in the background doing a bunch of things. So I'm Caesar. Gregg is my closest friend. Absolutely love him and absolutely love Brooke. So feel very honored to be invited. A little bit of background. I trained in emergency medicine at New York Presbyterian, so not far from where Gregg and Brooke are. So that was Columbia and Cornell. And then moved out to the San Francisco Bay Area 12 years ago to both practice medicine, but also to start up a company that really kind of looked at new ways of delivering healthcare, leveraging technology. And we created what's now Carbon Health. And we chose the name Carbon because it's like the, most basic component of life. And we created a network of urgent care, primary care, mental health, women's health centers in California and Nevada. And we've expanded through telemedicine as of this week, to all 50 states. So if you're in New York, you can actually access one of our providers and get care. So our coronavirus journey started January 23, when I got a Slack message from one of our providers in Mountain View, California, so near the Google headquarters, when 2 patients on the same day presented with fever and rapid heartbeat after having come back from Wuhan City. So they're both visiting family in Wuhan City. They weren't related, which is crazy, but came in on the same day. And we really realized at that point that coronavirus was in the US and probably had been for a while, even though the Trump administration had this kind of outward display of quarantine and control over a new virus. So what we did at that point was realize that we needed a way to protect our healthcare workers, and we created a symptom checker. So we're in a fortunate position in the way that super well-funded, huge, long-standing institutions like Columbia or Cornell in New York City, where they fail is that they're not nimble, and startups like ours are very nimble and capable. So we actually started our first Slack channel called Coronavirus right on that day, and got together our engineers, our doctors, and really came up with the ability for people to check their symptoms and inform us of risk factors for coronavirus infection. And by doing that, we probably saved countless infections within our own employees. So, if a patient was coming in with cold or flu symptoms, which is fairly common in the urgent care setting, we wanted to know whether they had, epidemiologic risk factors. And if they did, we would proactively reach out to them and prepare our staff at the same time so that that patient, before entering, was masked and everyone else was masked and gloved. And even though to date we've run over 10,000 tests, probably the highest in all of California of any one institution, we've had no healthcare workers get infected. So I'm knocking on wood as I say that, but because we know how fickle this is, but being able to protect our workers was an important thing, even though we knew that we were at high risk for having infected patients coming in. The next step of what we did is we started working with labs to create an at-home test product so that, again, patients could be at home, identify whether or not they're infected, and therefore risk stratified. And then through our software, we could provide healthcare to them, in their isolation, and monitor them and let them know if they needed additional care. So we're about to announce that the FDA finally, after multiple rounds of data submission, has given us the okay to do an at-home collection test. That's not just for healthcare workers, but for anyone. And those tests will be administered under the video supervision of one of our doctors. So that's kind of, there are a lot more details. We're working with the city of San Francisco, the city of LA, to run testing centers for them. And again, the thing that I'm most proud of and what's most relevant to this group is that we've been able to do this, essentially let business go on without infecting our employees. So the question of, how we can kind of convey that understanding to other businesses led to an initiative called COVID Ready, or Carbon for Business. Essentially, which is a very comprehensive way to initially test everyone in a site. And we're working currently with an investment firm called Brookfield in New York City, Postmates, which has over 100,000 employees around the country, multiple biotech firms where we are. And there's been a tremendous amount of need to essentially identify for businesses, like how do we kind of safely get back to work? And so we've created a comprehensive program for those employers. And I guess I could spend this time talking about really kind of what we're promoting as our approach to this, what the data show overall, and then what the science is for coronavirus. So I think, looking at the questions that were submitted earlier, what's the outlook for medical innovation around the coronavirus, so around vaccines? There's a tremendous amount of hype. And when you look at the real world data compared to what we hear from government officials, there's a huge disconnect. And I think that the motivation around that disconnect is that the Trump administration really is trying to avoid the fear and panic that probably rightfully needs to be out there for this virus. The fact that this virus is still present today and it's causing economic havoc, I think is leading the administration to do things that are less than scientific. And we're seeing that with the data out of remdesivir, the Gilead medication that's been shown to perhaps reduce the time of kind of disease of COVID in patients who are moderate or high risk. So when you actually look at those data and you compare them to remdesivir in other countries, there's a marginal benefit potentially. If you really kind of skew the numbers in a certain way, there might be some benefit. But the administration is saying hydroxychloroquine or remdesivir, or let's throw everything we can at this virus to try to stop it. And the fact is that this is an incredibly infectious virus. It spread, my guess is, in the US starting in November, December of last year. In our local community in Berkeley, California, we had a 51-year-old who had the flu for a week and then was hospitalized and then died, which is incredibly rare for a healthy 51-year-old who goes swimming every day to die from influenza. And so was that coronavirus? We don't know. But we do know that, at least in our community, that the death rate in February of 2020 was 20% higher than the death rate in February of 2019. So what accounts for that 20% increase? Coincidental, but probably some degree of not recognizing a new disease that's in the community. So the question around vaccination comes up. Coronavirus to me is most closely aligned with the coronavirus that's been around for probably hundreds, if not thousands of years. And it causes the common cold. Now, when I was growing up, I heard people say, if I only had the cure for the common cold, I'd be a millionaire, right? Like, we haven't been able to find a cure for the common cold. I don't know why we imagine that we can find the cure for or a vaccine against the common cold virus called coronavirus. Like, we all want it to happen, but the fact is that this is an RNA virus that mutates relatively quickly. And so finding a vaccine against it will be similar to trying to find a vaccine against HIV. Right? So those are very difficult because they're constantly changing. Now, coronavirus can change its form to be less infectious and less deadly, and that would probably be the best case scenario for all of us. But we just don't know whether the next form of coronavirus, when we see it in October through February of this year, will be worse or better. We just don't know. But we should all be prepared that it will be around and that there's probably going to be a second, maybe third, fourth wave of this virus. If a vaccine happens, obviously incredible, thankful. Let's let's take that for the good that it is. So I don't really have more insight than the idea that scientifically this virus is not like a brand new virus. It's been around and causing colds for a long time, and no one's been able to make it go away. Regarding treatments, I touched on it a little bit. Please don't do like azithromycin plus hydroxychloroquine. Like there are lots of things that you can read about things that may have worked in a certain population. But the fact is that scientifically, all of those reports are just that. They're just reports of people who may have improved, and they're not done in a controlled setting. So we don't know what the alternative is. Similarly, like, a lot of patients will say, oh, every time I get my common cold, I need azithromycin to feel better. Well, the opposite thing is that if you didn't have the azithromycin, you may still have gotten better. So I would put the treatments that you hear about in that same category. There's a question about home testing, and today you can go on to, I think the LabCorp is a commercial vendor of laboratory testing. They've released an at-home test for healthcare professionals. So if you report yourself as being a healthcare professional and you want to get an at-home test, you can do so today. It's about $120 for the test. But one thing to remember is that with all of the tests, including the ones that we're releasing with an at-home collection, that's not just for healthcare personnel, but for anyone, that the false negative rate is relatively high. So that means that if you have a positive result, well, for certainty, very close to certainty, and we think that it's greater than 95%, that positive means that you're actively infected with coronavirus. So the test is very helpful if you get a positive result. If you have a negative result with any of the tests, you go to LabCorp in your local community, or do this kind of at-home test, and you have a negative result, there's still at least a 1 in 10 chance that it's wrong. And frankly, some estimates are as high as 3 in 10. So 30% false negative rates. So just keep that in mind. Now with the antibody test, you have the exact opposite scenario. If you test positive on the antibody, you really can't rely on that at all. So that doesn't mean that you've had coronavirus, this deadly one, and you've developed immunity to it. The test does say that you've seen some sort of coronavirus, like the one that's not deadly and just causes the common cold, and your body has reacted to that with an immune response somewhere between 4 to 10 or more days ago. So if you were traveling in China in January and you came back and you had a really bad fever and cough, and then later on you learned about coronavirus and you want to know whether that was coronavirus, and you take this serology test, it may tell you that you're positive, and then you can try to put those two events together, that the travel to China that resulted in a bad cold was the coronavirus. That's a possibility. But it could also have been any of the other viruses that caused that test to go positive. Where the antibody test really shines, though, is if you test negative. And so what does that mean? So if you take the serology, so you do the blood test, please only use the blood test, the serology tests that are authorized under the FDA. There are lots of manufacturers that try to sell blood tests directly to patients, and many of them are just like nonsense. So the FDA has roughly 6 or 7 blood tests, serology tests for antibody that they've authorized for use. And LabCorp and Quest actually run them as of late last week. So you can go to your local doctor, get an order for it, or pretty soon you'll be able to log into Carbon Health and we can order one for you. But so the test is only useful, the blood test is only useful if you test negative, which means that you haven't had an immune response to coronavirus. And so just kind of take a moment and think about what that means. So the only real useful scenario is you traveled to China, you had a really bad cold, you were in New York City during the pandemic, and you were sick 2 weeks or more ago, and you're convinced that that was coronavirus. And now you've done the blood test, and the blood test shows that you're negative. So now you know that that wasn't the coronavirus. Now what? Now you still have to be worried and aware and careful. And frankly, if it was positive, we actually don't know whether, and assuming that you did have coronavirus, we don't know whether that means you're immune to it during the next wave. In fact, a lot of studies suggest that you're not immune to it. So that's kind of the state of testing, and then state of vaccines and treatments. And I'll pause for a second and ask for questions or feedback or.
I was going to pause for us to take a deep breath together.
Yeah, I've just thrown a bunch at you, but.
It was amazing. Thank you. So clear and so scary. So let's just take a breath. Yeah. Thank you. I feel like if other people are okay with it, if we continue on to the retreat center specific questions, just so, and then we can circle back to, because I think we could get lost in medical questions and not get to some of the more specific questions. And you can answer them as starkly as you feel they need to be answered, Caesar, or that you don't really have an answer for them. But I know you gave us some good advice on those fronts.
Yeah, for sure. So actually, Brooke, do you want to, should we do like question answer?
Sure.
Or Matt, you can choose the questions and I'll try to.
I feel like how likely are any of these medical innovations to be ready? I feel like you've sort of dashed hope of knowledge of that in the next 3, 6, or 12 months. We had the question of how much advance notice would we have if one of these innovations were to become readily available? And that question is important for a retreat center. Many of us have booked sort of 3 months, 6 months in advance. So knowing, and some of us are sort of like reassessing every 6 weeks whether we should cancel our programs. But say we were to find out that there was a vaccine or a very sure home test or something like that became known, would it be available? I imagine there'd be a waiting period at which point we could sort of get our staff together and consider reopening. So just any thoughts on that? We don't need to harbor long on that one.
Yeah, I think the most reliable thing is the swab testing as a way to filter people for first step. So we're talking about, there are no absolutes with this. So unfortunately, part of my advice will have to do with what kind of risk state you as an individual, as a business owner, and your staff are for coronavirus. So if you have a history of diabetes, high blood pressure, cancer, heart disease, and you're older than your 50s. You are in a different risk tolerance for all of these decisions. And that should 100% play into your approach to reopening or accepting people coming in. So I'll give you an example. If you have a group of people coming into your center, and today we have the capability of screening all of them at the door. We're doing this for businesses in California with a rapid test. So the rapid test will give us an answer within 15 minutes. Now you have, let's say, 50 people who are planning to spend a few weeks with you. And each of them has to undergo the rapid test to see whether they're actively infected or not. So if the rapid test is positive, you're pretty sure that they shouldn't be with you. If the rapid test is negative, there's a 1 in 10 to a 3 in 10 chance that it's wrong. So if I'm 75 and I just battled cancer and I have had a history of heart attacks, those odds are too high for me to reopen my center, to open my doors to new people, especially if we're talking about scale. If I'm 25, maybe that's a different calculation. So the reason I'm kind of framing it in this fashion is that it's kind of case by case, and it depends on your own individual risk tolerance for each of these decisions. And I'm happy to be, a guide, around your own individual decisions for these things. But again, I'm painting the picture of, we have a 15-minute rapid test that's the best in class scientific test available. Even if you had that at your door, you still need to make some hard choices.
Can I ask you specifically with that, if somebody were to, sort of two questions, if somebody were to contract it on their way up, how long do they have to have had it in their system for it to show up? Because some people are traveling over airplane. And then the flip side of that, if somebody were to fly in, get the corona, or be exposed in an airport, arrive at a retreat center for a 4-day retreat, could they give it to all the retreat participants once arrived in a, in a 2 to 4 day span?
Yeah, so I think, so again, those additional steps will reduce your risk. So if you have roughly, in our own data, we're seeing that roughly of patients who are completely asymptomatic and get tested, so when we're doing broad screening, about 6% of them are still testing positive. And again, a positive test is really reliable. So those 6% of patients who exhibited no symptoms at all have the virus. And they can shed the virus up to 4 weeks, according to some studies in China. Now, shedding the virus and spreading the virus, we're not quite sure if those are the same things. So we know that the virus lives in the mouth, in saliva, but can also be shed in stool. So if you had someone flying in and you wanted to, one, test them and then quarantine them for a period of time, I think you kind of look at probabilities again. So if they tested negative, we're going to say in the best case scenario, there's a 10% chance that they're still a carrier. And then if you quarantine them for, let's say, 4 or 5 days to see if they develop symptoms, and they don't, well, it's the minority, it's a very small minority of patients, again, maybe 20% or fewer of patients with coronavirus who are asymptomatic. So now you're multiplying the probability of 1 in 10 with probably the probability of 1 in 5. So now you're down to a 2% risk that that person actually has coronavirus, tested negative on the PCR, and never developed any symptoms. And for you, that might be an acceptable risk.
Mm. And how quickly could they, and maybe you don't know the answer to this, but if somebody were to come to a retreat, could they give it to retreat participants having been exposed on their way in?
So there's a good study out of South Korea that looked exactly at that in a workplace environment. And then there's another paper that was published about an infected patient on an airplane and then all the other people around them who got infected. So it's prolonged contact. And by prolonged, we mean more than just passing by. So, you know, face-to-face or close proximity for at least a couple minutes. But that's all it takes, frankly. And in a retreat setting, I imagine that's a common thing, is kind of being close to each other.
You're muted, Brooke.
What's that?
Someone could be exposed to it on a Monday and be shedding it or potentially infecting other people on a Tuesday or a Wednesday?
Yeah.
Okay.
Oh, I see. From the time of exposure to the time of shedding, it's not really well understood. So I can't say, but we do know it's on the order of days and not weeks.
And for those of us who are interested in 100% clarity around a quarantine, so if we were to have residencies and we had someone test negative and then be quarantined, how long would you recommend a quarantine? Say somebody was coming for a 3-month residency, how long of a quarantine would you say would get people to 100% certainty that they are not carriers of the virus?
So I think if you take, and this is what we're advocating for a lot of businesses, and I think I would recommend the same thing for this group. What I would do is I would test people on the day of arrival, or within a couple of days of arrival with the swab. And if they're testing negative, we're now down to a 1 in 10 to 1 in 30, to 3 in 10, so 30% chance that they might be a carrier. If you ideally, so I'm creating like the ideal scenario, and it may not be possible, but if you wait somewhere between roughly about 10 days later, and you do the blood test, and that test is negative, then I think you can feel pretty comfortable that they're coronavirus free. So again, the blood test is useful if it's negative. The swab test is useful if it's positive. So the swab test says, are they infected today, yes or no? But if it's negative, there's a chance that they could still be infected. You have to wait about 10 days for the blood test to be useful for this entire period of time. If the blood test is then also negative, I would say that that's pretty much as close as you can get to certainty in someone who doesn't have symptoms.
And is the blood test, if there's a question, do we need a medical personnel in the center, or would you be sending somebody to a lab corps, a local lab corps?
We're working with LabCorp to figure out what their capability is. Today, they're not accepting people to come in for that blood test when it's for coronavirus. They do have the capability. They are expecting to have that capability. So I would assume that either that person goes to the local doctor's office, has a blood draw done, or to LabCorp.
And if they come up positive with the blood test, how long would you quarantine somebody till you feel very clear that they are not going to be able to shed it?
The safest answer is going to be 3 weeks to 4 weeks.
Okay.
The reality is that we know for sure for a couple days before they exhibit symptoms to a week or so beyond their fever, we know for sure that they can spread it during that period of time actively. We also know that they can shed the virus particles for up to 4 weeks. So I would say that clearly if they're having fevers and they're sick, you have to wait at least a week beyond that for that person to interact with anyone. But if you want to be 100% sure, it would be the full month.
The full month after they showed symptoms.
From the beginning of their, from the beginning of their illness, yeah.
Okay, thank you. There's been a number of questions about cleaning the center. So if somebody, we didn't know whether somebody had been a carrier or to just be extra safe, is letting bedrooms lay fallow or meeting rooms lay fallow for a few days? How long should we do that in between guests, in addition to cleaning with extra strong cleaners, and or maybe not even having our cleaning people go in till it's laid fallow for a number of days? Do you have any best practices, thoughts around that?
Yeah, I would say that shared surfaces being cleaned is clearly critical. In the hospital setting, we don't allow the rooms to necessarily air out, which is, I think, what this question is getting at. So, so coronavirus, there's some thought that in someone who's coughing or undergoing medical procedures, it can aerosolize, so it can go into air and be spread that way. I think the vast majority of the data still show that this is more of a droplets on a surface way of passing it, or droplets going into your body, either through your eyes, nose, mouth. And so I think my recommendation around rooms would be that as long as everything is cleaned with just your Lysol, Clorox, whatever it is, that should be safe enough, frankly. And you wouldn't necessarily have to ask your cleaning people to not go into the room. Now, the cleaning people should for sure have masks and gloves on so that they're not inadvertently, touching a surface before they clean it and then accidentally touching their eyes or rubbing their eyes, because that would be a common way of catching infection. But what you see with like the hazmat suits, you've seen probably news stories where people are just gowned with these complete head to toe, outfits on. We are required to do that in the hospital. Like when I intubate a patient these days, because of hospital policy, I have to wear those. The idea is that when you're getting into the lung area, virus particles can get aerosolized. In our urgent care clinics, we don't do that at all. We just have our employees wear masks, goggles, in case someone coughs in their eyes, and gloves. And again, after now almost 2 months of active testing and 4 months of having people in our clinics, or 3 months of having people in our clinics with this, we haven't had anyone catch the virus. So, and we don't air out rooms in between patients. We don't do any of that stuff.
I'm reading, if we have a staff exhibiting symptoms and self-quarantining, should we be closing a building down or just going in and cleaning extensively?
Yeah, I would say just the cleaning. So this isn't tuberculosis, right? This isn't an airborne virus. This is, you should treat it like a droplet virus. And you're going to hear tons of news stories, because that is kind of like, there might be OSHA regulations around, making sure that everyone's like airing out rooms, closing down buildings. I don't know about that, but I can tell you from a scientific perspective that, frankly, just making sure that the site is clean, and that's like, every surface that could be touched. So if you have like a radiator in the bedroom, and you don't typically clean the radiator, that might be something that your staff has to be retrained about. Clearly, doors. Yeah, sorry.
Like pillows under pillowcases, should we be washing?
Oh, that's a great question. I don't know, but I would say yes.
Yeah.
I would say yes. Yeah.
Can I ask you about contact tracing? New question. If somebody at our facility is positive or comes down with COVID, or somebody who was recently at our facility, with contact tracing, are we going to be then notifying every person who's come through the doors since that person came to our facility? Is that?
So anyone with prolonged exposure to someone who's positive should be notified and tested. That's kind of the general rule I would use. It wouldn't be like, I have the virus, I was in your center, Monday morning, and then someone else came in there like Monday evening and is not exhibiting any symptoms and is fine. That's not considered close contact with someone who's positive. So theoretically, though, you can kind of assume, like, if I was there Monday morning and I was really sick and I'm like coughing everywhere and I'm terrible about cleaning up after myself, I can understand why people would worry about those scenarios. But at least based on CDC guidelines, they're not recommending closing down rooms or businesses in those scenarios. And when we have positive patients in our urgent care centers, we just look, we actually have video, so we can see who's been in close contact with the patient, so that we can inform them. And luckily, nothing has come of any of those cases.
And is it legal, and I don't know if you'll know the answer to this, but for us to screen people based on medical history, and I guess that could either be for staff. I've wondered about that with the people. I've heard that people, EMTs who are elderly have been furloughed. I don't know what the legalities are around that, but in terms of screening people coming to a retreat center or working at a retreat center, do you think that runs into legal questions? And if you don't know the answer, that's totally fine.
My guess is no, but I don't know New York State. California, we have pretty harsh laws, and as long as you make accommodations for your employees that are alternative accommodations, it's considered fine.
I have a question. Could centers require participants to test prior to their arrival with a negative result, and we're able to have 6-foot distancing, one-way traffic throughout with 6-foot distancing at all times and doors open? Does that seem like a safe scenario?
Yeah, so again, it goes back to your risk tolerance. So a negative test prior to arrival, Brooke on a prior call had mentioned, what if they're taking a train up? What if they're flying in? So there's a risk of contracting the virus en route. And so, but having said that, again, if they have a negative result, you're sure that they haven't gotten anything on their way, and they're maintaining 6 feet distance, I think that's very reasonable. Right. Because that would kind of get at the lack of spreading with close contacts. So close contacts is considered less than 6 feet distance for a prolonged period, so on the order of minutes together rather than passing by. Now, having said that, there's clearly loopholes in that, the asymptomatic patients, the patients who have a false negative test. But you could maintain that until they get a blood serology test a few days later. So remember, with the blood serology, it's looking for an illness that occurred somewhere between 4 to 10 or more days ago. So, so you'd have to kind of maintain these precautions for some period of time before the serology test is useful.
This has also just come up in our center, where even with 6 foot distancing, we were having 6 foot distanced bonfires with our staff. And I realized that though we were maintaining 6 foot distance, we changed seats multiple times around the fire. And so then you're touching things. So I've been thinking about like assigned seats at dinner or assigned seats in the meeting room. So that, I mean, again, since you're saying now it's more droplet than air, being really careful that you don't have a lot of overlapped spaces for people to be in. Does that?
Yeah, that seems really smart.
In terms of food service, obviously there's plenty of restaurants and hospitals that are doing catering, and in that many of the retreat centers have food service options. There have been questions about whether we should be requiring groups to do their own food service, or, you know, do you feel like there's safe ways of doing food service that won't in particular infect the staff?
So one of the scary kind of data points for food is that the virus does really well in like a refrigerator. So it can last for months in the fridge on a surface. Now, you know, those are in like scientific studies rather than the real world. Like it wasn't like someone who had coronavirus then 2 months later went into the refrigerator and like swabbed and saw it. It was more like, under what conditions does this virus die? We know on heated surfaces, it dies pretty quickly. So, so in the sunlight, as much as I hate Trump, like this one he got right, like in the sunlight, the virus dies because it overheats and it's not stable enough. It's probably the only thing that I've agreed with in all this time. But in the refrigerator, it can actually be preserved for a prolonged period. So that gets to like fresh produce, good food handling. I think anyone working in the kitchen needs to have masks and gloves on. Like that's completely, there's no way around it. Like if they cough and they're infected, or they touch their mouths and then they're preparing food that's not cooked, it puts everyone at risk. So, so for food services, I would say that you can continue them with those precautions, with the understanding that cooked food over, you know, over kind of fresh food is preferred for disease transmission. Now, if you're taking the other precautions, which is the swab test of someone who's coming in and then days later getting the serology and everyone's negative, then I think that, you know, you're already at a super low risk of having this virus in your community. And so, you know, taking these additional precautions around like not serving raw foods probably wouldn't be necessary. Just in general, if there are like big bowls of chips or, you know, if there's shared food, like we know for sure in the best case scenario that the highest rates of like E. coli, right, are in those shared bowls. There's a study that, so I have some degree of OCD. I think Gregg can probably attest to it from when we were roommates. But there's a study that showed kind of what happens when an employee brings in a bowl of candy and you have other people, you know, in the group kind of reaching in and grabbing candy. It's like in the entire office, like even compared to the bathroom, that is the dirtiest spot to go to. And so it's just something to kind of keep in mind as well for coronavirus.
I will remember that forever. So we only have 8 more minutes. We want to respect your time, and maybe we'll give you a group like shout, cheer, thank you at the very end. We've got 2 more questions, and I think I'm gonna have to call it that. One is, can you share a little bit more about what a COVID-ready protocol or what your COVID-ready protocol looks like for staff to be and how we might transpose it for our retreat centers, but even just sharing more about what COVID ready workplace looks like in your clinic. And then the last question is, should we be checking in with participants after they've left after 2 weeks or 4 weeks and just check in to see whether anyone came down with anything?
So both of those are great questions. So one is the Chrono, the COVID Ready program. So I don't lead it. I'm just I can tell you what we've done in our own clinics. But in general, there are 3 components to it. One is education and prevention. The second is monitoring and testing, and the third is management and containment. And so the way that we approach it, at least, is through the on-site testing or PCR testing, the swabs, and then having patients, or in this case, participants, and employees, have a daily reminder to tell us what their symptoms are. And that is like having chills or body aches, or, in our data set, roughly 3 in 10 people who are coronavirus positive didn't have a fever. 2 in 10 didn't have a cough. The most common symptoms were actually body aches, and I want to say some respiratory issue. But it was a good number. Chills. Chills was the other kind of common one. So what we've done is, through software, we're checking in with people regularly, rather than having someone on your team going out and doing a daily phone call or a weekly check-in, which may miss things. We do it through software. I'm happy to share with you guys a deck that the team put together. And this is just kind of a general deck that they shared with me. And then what Carbon's done is we've created a dashboard for every institution that says, these are the people and here are the symptoms and these were the test results. And so there's a degree of monitoring that we are promoting, and that we think is critical to know, if someone does turn out to be positive, to kind of turn back the clock and say, who else was at risk for contracting coronavirus from them. So I'm kind of answering both questions in the same fashion. And I'm trying to figure out, Greg, if I send this to you or Brooke,
We can share
I've got like a link to it that I can send through Dropbox, if that helps.
That'd be great. We can share it out.
Yeah, if you want, you could also put it in the chat if it's just a link.
Oh, okay, let me do that. And awesome, I see it.
So in our last 5 minutes, we may have time for one more question if anyone wants to shoot one this way. It also just occurs to me that it might be useful for us to have, I don't know, I've just put it out there, a buddy system or some small groups if people want to sort of hammer out their own plans or what they're thinking post this conversation and post some of the other conversations. It would be very useful for me to sort of buddy up and organizationally and kind of be like, okay, this is what we're looking at. Does this make sense? And just kind of, yeah. So does anyone have any other questions? I'm seeing a lot of gratitude notes.
Brooke, maybe we can ask people if anybody does write plans, if they could share it with Ben and we can post it on the website.
That would be amazing. And I recorded part of this. Did anyone record the entire? Yes, I'm seeing smart, organized people who recorded the entire thing. So maybe also letting us know, are you comfortable with, Caesar, if we share this with our coworkers?
Oh yeah, for sure. I mean, yeah, and just so you guys know, I'm like the medical side of the equation, like not necessarily the business side. So the Dropbox that I shared, it's all like from the other team. But if you have like medical questions specifically, feel free to email me or go through Gregg and Brooke. I'm happy to help in any way for specifics. I love that you guys are creating a community around this, because having, you know, your centers closed down for this virus is obviously like a huge hit to not just your own organizations, but everyone else that you're serving. So
I'm wondering in our last 3 minutes if there are others who want to just offer some gratitude to Caesar. If you raise your hand, I will call on you. Jean.
Caesar, I was actually just raising my hand to show you gratitude.
Oh.
The news was really hard for us. It's very stark, and we better know how to go forward when we have the right information. So thank you, Brooke. Thank you, Gregg. Thank you, Caesar, for putting this together. It's really been great.
Thank you so much. Yeah, thanks for listening. And of course, if there are updates, like maybe, you know, we can do this again in a couple of weeks, or as things evolve, I'm sure questions will come through.
That is an incredibly generous offer, and I can well imagine I'm seeing a lot of shaking hands and yes, please. So yeah. Well, we are so thankful. Wish you and all your staff as much. And in addition to everything that Caesar does with his own organizations, he's also in other ERs. Staying with Caesar as a house guest, I pretty much didn't see him the entire time I was there, because he's out so early in the morning and home so late at night. And this is pre-COVID, so I can't even imagine how you all are holding up. But we send you love, and we will be in touch. And I'm sure you have lots of people who would love to host you once this is all over. So
thank you. I would love that.
Around the country. Yeah.
I would love that. I know we will get through this and things will get better. So I'm really looking forward to meeting you all.
All right. Thank you.
Thank you. Just a couple of housekeeping tasks before we leave. Thank you, Ben, to recording this. And so Ben will share the recording and a reminder for our next community call. And I just, again, want to pay gratitude towards Gregg and Brooke for raising this up and connecting us. And thank you so much, Caesar. It was a lot of information, a lot of sobering information. And personally, it was wonderful to hear it in such a calm way that was accessible. Much gratitude to you and the way you delivered that. Thank you so much for offering this time and future opportunities. And so everyone on the call, please look forward to Ben's email, and hopefully we will see you next Tuesday for the community call on opportunities with local partnerships. So be well, everyone.
Thank you.
Take care, everybody.
Stay safe.
Shalom.